Getting a fertility second opinion after IVF or not getting pregnant. What you should know. Hi friends, I'm Dr. Natalie Crawford. I'm a board certified OBGYN and REI. I'm a fertility doctor in Austin, Texas, and I will be honest, our practice is very small and personal for fertility, and we see so many people for second opinions. The reason why this matters is that I spend so much of my day looking over IVF cycles from people who have done these cycles at different places and not had the outcome that they needed to have. And I always get asked, is it okay if I get a second opinion? I'm nervous to get one. What will my doctor think? What do I need to know? And I'm telling you from my end, like, how do you know when you need to get a second opinion? Because the truth is, not every cycle is going to work. So how do you know if you're getting the information that you need to get? So first of all, please subscribe to the channel if you're interested in learning more about your fertility and your body. This channel helps spread knowledge and awareness. Second of all, in order to understand if you need another opinion, you need to understand your expectations based on your age, your ovarian reserve, your medical conditions, and what should normally happen in IVF. I am a huge believer that your team should be walking you through this, meaning when I have a patient go through, they know what I am expecting them to get. How many eggs are we looking for? How many embryos should that be if things go normally? Now, sometimes things don't go normally and it's not your doctor or your clinic's fault. It's just how things are. Maybe it's why you have infertility. But having visits and appointments and understanding this, having a clear plan of action of what you're going to do next, and having a place where you can get your questions answered, this is all part of what we're trying to accomplish when you're going through IVF. So first of all, really quickly, I have lots of content on IVF. There's a whole playlist full of other videos. But if you're going to go through IVF, let's understand this very fast. IVF is in simplicity trying to get 1 month's group of eggs to grow, taking those eggs out of the body, fertilizing them in the lab, making embryos, maybe doing genetic testing, maybe doing embryo transfer. Outcomes are different. How I view this is there's one set of outcomes for an IVF cycle. Did you make embryos? Were your embryos normal? And then you have normal expectations, meaning if you're 40 and you made 2 embryos and neither of them were genetically normal, that is absolutely appropriate for your age. That's not a failed cycle. That is as expected, but you made embryos, you need more, do it again. Now, how many eggs did you get? Was that normal for your ovarian reserve? Did you meet the mark there, or is there something that can be improved? On the same end, if you're 25 and you made no embryos and you got 20 eggs, that is not normal. What happened? So we don't like to look at failure, and I hate that word. I've had failed cycles. I understand it. I use it sometimes, but really we're talking about expectations and where did you fall off of them and what is to be expected and what is based on your clinic or your doctor, and when are they not paying attention? Somebody today sent me their cycles and they've done 4 cycles, and easily I can look and see the same issue happening in everyone. Their eggs are not mature, getting 20 plus eggs and you're only having 5 or 6 mature, all of these immature eggs, yet their doctor is triggering them the same time every single cycle. They're not even looking at the data from before. And here's the thing. Your very first cycle, we use averages. So what I'm about to roll through. And that's okay. You are very individualized. So if the average person has follicles that are mature from 15 to 20, some people have 14s mature and some people don't. Some people have 21s mature and some people don't. Until you go through, I don't know what your data is. But once you have gone through, we should do better because now I have data for you and I can be very, very personalized, even more so than where we started, because now I know how your body responds to these medications. And to be honest, that's what a lot of clinics are not doing. They are just protocoling somebody through on the same cycle over and over without even taking a moment to look at what your history has been or what you've been through in the past. When you do IVF, 1 month's group of eggs. Everybody has an independent number for which we would expect by you. That's based on your ovarian reserve or your AMH and your antral follicle count. The younger you are, the more you have. As you get older, no matter what, you start to run out. There is month-to-month variability. So if you come in and I count an antral follicle count of 14 and you're age 37, and I say this is very average, fantastic, it very well may not be 14 the next month, also okay. But it should be within 30% of that either direction. So if you're stimming and I only see 4 eggs growing, that's not okay. That's not normal. Your cycle should be canceled, or at least it should be discussed, and you should be given the option of cancellation depending on your scenario. Getting these eggs to grow is not something your body wants to have happen. So 14 eggs outside available to grow in a given month. In a normal cycle, 1 egg will ovulate, the rest will die. In IVF, we're trying to get all 14 to grow, and your body doesn't want that to happen because your body doesn't want to have 14 babies at one time. So this is the real art of IVF. This is the protocol. With that protocol, I'm coming in with medications to sequentially suppress your body and then stimulate. Suppression varies person to person. Nothing, birth control, estrogen, progesterone, Lupron, ovulation blockers, testosterone, and combinations of these medications. Stimulation is mostly FSH, injectable FSH, same hormone the pituitary gland makes, higher doses than it normally would make. Often you'll add in some Menopur, which is a combination FSH-LH medication. And then sometimes there's human growth hormone, Clomid, Femara. Those are other types of stimulation medications that can be used together. But the point is we are overriding the brain's normal systems. You monitor along the process, ultrasounds to measure size, estrogen levels, and we make a decision about triggering based on their size and your estrogen. Now, things impact this, meaning everybody's a little bit different. So as we're gauging the size, we're trying to get the most mature as possible. In general, a mature egg will make 200 picograms of estrogen. So we can use that metric to gauge how many eggs do we think are mature based on their follicle sizes. And we're balancing this by your protocol and not wanting you to get OHSS or ovarian hyperstimulation. So it is not perfect in any way, especially that first cycle, because we want to do things safe. If you're doing a fresh transfer, there's a whole nother set of metrics that have to be met. But in general, the hallmark of a good protocol is getting as many mature eggs as possible that correlates with your ovarian reserve. And if we get that, fantastic. Things that happen in the lab as far as fertilization, growing out to embryo, and genetic normalcy, typically, you're going to see about 75 to 80% of eggs fertilized with ICSI, and then about 50% of those make it to a blastocyst, which is a typical day 5 or day 6 embryo stage of implantation. Most modern clinics do not transfer day 2 or 3 embryos anymore, and if your clinic is, I am highly suspicious, and I want to know why, because that is not what we're doing. We're making embryos declare themselves. Your lab needs to be modern enough to get embryos to that stage. It's harder, okay, but it's good. If your embryo can't get there, there's much lower chance they're going to make it inside your body, and then you're just doing transfers and spending your money and your time and your emotional and physical energy not getting to a pregnancy. Once you have a blastocyst, your normalcy rate is going to be based on your age. So that 40-year-old is going to have 25 to 30% of their eggs genetically normal. A 35-year-old is going to have 50 to 60%. So based on your age, I'm going to have a different percentage normal or not. And that's why if you're 40 and you only send off 2 embryos, it's okay if they're not genetically normal. We hoped one would be, but if they're not, the truth is you needed more embryos to get to that. And if that's where you got and, you kind of fell perfect for your age, then you need to do it again. And maybe there's 0 changes to be made. And I tell patients this, our protocol did its job. We got the number of mature eggs we expected based on your ovarian reserve. Everything through the lab looked perfect. The math wasn't in our favor. That's how it falls based on your age. So let's do it again. Sometimes your percentage is less than your age. And then I say, well, let's look at egg quality and sperm quality. And should we add in human growth hormone or CoQ10, or are you smoking cigarettes or marijuana? Or what can we do to change the environment or decrease inflammation? So the reality is, if you are doing the same cycle over and over again, and you're not getting the outcome that you are expecting to get, that's not a good sign. That is either the outcome is actually normal, yet your clinic has not prepared you for it, or you are performing less than you should, and your clinic's not taking the time to personalize this. I am a huge believer in the WTF appointment, or like, it happened, right? Like, what happened? And having somebody go through the cycle with you and break it down. I'll be honest, sometimes I do this just in messaging. Like, we have a portal, and I'll be like, hey, here are the high level points. The protocol hit its mark. We got as many mature eggs as we wanted to. We only made 2 embryos. Neither were normal. That's okay. Remember, we only expected 25% to be normal. We knew we'd likely need to send off 4 embryos to achieve this. We're going to do it again, the same protocol. Sometimes I'll say, I'm going to make X or Y change. Sometimes I say, let's meet, or I give you the option. Here's what I want to do. Do you want to meet and talk about it? But somebody who never meets with you, who's just doing the same thing over and over again, huge red flag. A clinic that will not cycle you based on your ovarian reserve, especially if you're young, okay? There is a breaking point where it makes sense. But if you are 38 and younger and somebody's saying no based on your AMH alone, and you're still having periods, meaning you're not in ovarian failure or menopause, red flag. Get another opinion immediately. And somebody who tells you you need a gestational carrier and you do not have history of a uterine trauma, or you haven't done multiple failed embryo transfers, which is defined as 3 or more euploid embryos that have failed, that's a red flag. Why are they telling you you need somebody else to carry the baby? Maybe it's the case, but why? If they can tell you you have a visit and they explain it, fantastic. But if they can't, or if somebody just says you need donor eggs because you haven't made normal embryos, maybe that's a cheaper or a more efficient way, but is that the only way? Getting your questions answered is really at the root of the problem. And I think that's something that so often is overlooked, and people don't know how to be their own advocate. So learn more about IVF so you can be your advocate. You can sign up for my Enhance Your Natural Fertility program or the IVF course. Those are on my website at nataliecrawfordmd.com. You can watch the IVF playlist or listen to the As a Woman podcast, or follow along on Instagram for more information. I'm going to be pulling questions from here, so please put them in the comments. Thank you, friends.